everyone. Welcome to another lecture, and today we'll discuss something about growth and growth, especially in pediatric population. And with this, we start our lecture. So, what is growth? Growth is net increase in size of mass of the tissue, size of the mass of the tissue. Okay, so total increase in size of the body or the size of the uh, tissues or the organs inside the body, that is known as growth. And technically it includes everything like hypertrophy, hyperplasia, and normally all that shebang that occurs in pediatric population as they grow. Development, on the other hand, means that maturation of function. So maturation of function is related, maturity of functions. So it is related to the neural growth and the maturation of the nervous system rather than physical appearance and physical structures or the physical attributes of a patient, of a person. So that is what development means. So growth and development are usually interrelated and they heavily correlate with each other. Now, what are the factors related to growth? Factors which impact growth. Okay. So first we take as fetal growth. So what are the factors which affect fetal growth? So fetal growth is primarily influenced by three factors. That is the fetal factors itself. The second are the placental factors, and third are the maternal factors. So all three factors are very important. So we will begin one by one with each and every one of them. So first factor is genetic potential. Now genes decide everything. Again, you know that genes, when they are influenced by environment, they respond in a different way. But if they are not influenced by environment, they always respond in certain way. So genetic potential of a child is very important in growth. And newborns of taller parents have longer limbs, and they are taller, or they have increased length compared to their normal counterparts or the counterparts having lower mean parental height. Okay. Second one are the fetal hormones. Now, which are the fetal hormones that are important for growth? So you have to remember that human fetus secretes thyroxine. Thyroxine is secreted by human fetus at 12th week of gestation, and this plus insulin is very important for the growth inside the uterus or the womb of the mother. So these both are two important hormones which are important for the growth of children. And in later pregnancy, steroids have a role too. Steroids also have a role in growth. So we see three important hormones, 1, 2, and 3, which have a significant role in the fetal growth. And these three hormones are very important. And mind you that you might have noticed that there is no significant role of growth hormone in growth or in the development of a child in womb. So in utero development, there is no role of growth hormone. So imagine you have a patient with growth hormone deficiency. When you have a newborn of growth hormone deficiency, this child usually will not be SGA or IUGR. The child will not be short for gestational age. If the child has growth hormone deficiency, the features that the child will present with are micropenis, prolonged jaundice, and hypoglycemia. These three important features will be present with growth hormone deficiency in a newborn, but the child will not present with growth failure. in utero. Later on, postnatal growth failure will occur, but there is no in utero growth failure. Now, third one is gender. So obviously, we know that male newborns are heavier and taller generally than female newborns or female in utero. Okay, so this is a very studies proven fact. And fourth one is insulin like growth factor 1 and 2. You know that insulin like growth factor have a very, very important role. And usually it is IGF-2 which is developed, which is important in the in utero growth. And again, they are the reason why there is increase in size of the baby or increase in macrosomia in infants of diabetic mother, because insulin acts on the insulin like growth factors, and which causes the child to grow in a bigger size or macrosomic child in utero. So you have to remember that IGF-1 and IGF-2 are also very important factors. Then the next plethora of factors are the placental factors. So what are the placental factors? If the placenta fails, to grow with the child, usually placenta at conception is smaller at size. Later on, it gains size slowly. So the increase in size, if it is not in sync with the increase in size of the fetus, then what happens is that it fails to survive. It fails to supply adequate nutrients. It fails to supply adequate blood. It fails to supply adequate raw material for the child to grow. And due to that, what happens is that the child will become IUGR. So in intrauterine growth restriction or retardation is commonly seen if the placental factors are abnormal, if the placental vessels do not grow with size, or if the placenta itself does not grow with the size, or the fetal capillaries or the all the connections are not proper. So placental factors are also very important. Then finally, there are the maternal factors. Now, maternal infections like torch will lead to IUGR. Maternal use of drugs will also lead to IUGR or multiple birth defects. Even torch is associated with multiple birth defects. So again, the growth and the development is related to maternal drug use and maternal infections. And again, if there are maternal diseases like eclampsia, pre-eclampsia, or if there is teenage pregnancy, if there are a recurrent pregnancy, or if there is not adequate spacing between two pregnancies, if there is maternal anemia, maternal malnutrition, if there is multiparity, all these maternal factors are very important in the growth of the fetus. So with this, we are done with the prenatal factors. Now, postnatal factors, which influence the growth of a child. So again, we begin with genetic factors and syndromes like Prader-Willi syndrome, syndromes like Down syndrome, Edward syndrome, or Russell Silver syndrome, or Patau syndrome. Okay, so all these syndromes, the child has restricted growth, the final height is less, even in Turner syndrome. While in syndromes like Soto syndrome, which is cerebral gigantism, or Klinefelter syndrome, the final height is increased. So here there are short stature, and here the child has long stature, child has macrocephaly or megancephaly. And again, the genetic factors are very, very important, and genetic syndromes are again very important. Now, there is something we know as IUGR. IUGR is actually a diagnosis when the child is inside the womb. Later on, it gets converted into SGA. SGA is small for gestational age. So you see that we plot the graph of the weight according to the age. And those if the child is IUGR, so IUGR is a diagnosis which you label the patient in utero. Later on, after the child is born, you label the child as small for gestational age because IUGR is intrauterine growth retardation. It is not postnatal growth retardation. So IUGR is a in utero diagnosis. While this is a postnatal diagnosis, and significant overlap between them is present, and IUGR child may become SGA child. Okay, so SGA is usually diagnosed by pediatricians, while IUGR is diagnosed by your OBGYN doctor, by the USG. And now there is something known as Barker's hypothesis. Now, what is Barker's hypothesis? Barker's hypothesis says that the children who are IUGR have increased tendency of obesity, type 2 DM, and insulin resistance. All these metabolic diseases that we see nowadays, they are increased in patients who are IUGR at birth later on in the life. So this is a potential MCQ and it may be asked. Now, in a IUGR patient, you have to remember that usually the patient who is IUGR or SGA, usually 80% of the patient recover within 1 year. The growth recovers within 1 year. In children who are IUGR or who are SGA at birth, 80% of the patient recover within 1 year. They normalize along with their peers when they are given adequate nutrition. 10% of them remain parallel. So their growth, they are small, and they remain small for rest of their life. 10% of them, and 10% of them have significant growth failure, and they will never recover. This 10% of patients who remain parallel, later on they may recover, but this 10%, the last 10%, never recover. So this is the trajectory that we usually see. I will show you that if we consider that growth trajectory, so this, if we take this as a trajectory of a normal child, okay, so now considering that this wait, give me a minute, wait. So if the growth trajectory is something like this is a normal growth trajectory. The child is, suppose, say, born of 3 kg. So normal growth trajectory is something like this. 80% of the patient within 1 year who are born IUGR will begin from here. They have restricted growth at birth, but later on they will recover at 1 year of age. Consider this at 1 year of age. This is birth, and this is the 80% that we have seen over here. 10% of them begin here, and then they remain parallel like this. Okay, they remain parallel from the normal growth, and the rest 10%, last 10% will falter. Either they will go parallel or they will falter like this. So 10% is here, 10% is here, and 80% is like this. So this is the growth. This is the growth versus age graph, and you see something like this. This is a rough graph, not to be scaled, and this is how the growth works. Usually, again, the feeding practices are important. If the mother does not adequately feed the child, or at 6 months of age, the mother does not wean off the child or does not introduce complementary feeding, then usually we see faltering of growth even after 6 months. And that is one of the most common cause of severe acute malnutrition in our country. The third influence is hormonal control. And here what happens is that hormonal control is very, very important. And you have to remember that thyroxine is very important in growth postnatally also. Then estrogen is very important postnatal growth. Why? Because see, it increases the growth velocity. But it also closes the epiphysis faster. So you have to, that, females usually have earlier growth spurt. Females have earlier growth spurt. have earlier growth spurt, but due to estrogen, the closure of epiphysis occurs earlier in female. Thus, the final height in males is higher than females because the estrogen which closes the epiphysis or which closes the growth plates is not present in males. And due to this, estrogen is also, given twice after thinking twice in Turner syndrome. You cannot give to any patient because it will limit the final growth height in the patient if introduced very early in the age. Okay, so this is the hormonal control and even the gender control, that females have earlier growth spurt while the final height of the boys is higher. Nutrition is again very important. Weaning off and complementary feeds at 6 months of age, and after 1 year of age, usually the child can eat everything the family eats, but sometimes they do not give all this, and they give those diluted gruels and all the local foods that they get, and due to that there is nutritional deficiency, and SAM children, severe acute malnourished or moderate acute malnourished children, have restricted or retarded growth. Recurrent infections, again, it influences growth. It causes something of growth abnormality, and recurrent infection always influence growth. Emotional trauma is also a very important and now widely recognized cause of growth failure. Then chronic steroid use and chronic inflammatory conditions. So chronic inflammatory conditions, like when you have patient with IBD, or you have a patient with TB, you have patient with asthma, all this chronic condition, they will see all the nutrients that are required for growth, they will be directed to fighting of the inflammatory condition, or they will be consumed by the inflammation or the infection. So it will cause restriction of growth. And again, steroid, steroid decreases the final height, and it suppresses the growth hormone and all the ACT, the RAS, HAS axis. So all that you know. Now, socio-economic factors, we will go them very briefly. So what are the factors that increase, the increase economic condition? So higher the income of the family, better is the growth. Okay. Again, it is not symmetric. There are skewed data, but again, you have to remember the richer, the higher, high socioeconomic level, higher or the better the growth, or more consistent is the growth. Poverty is associated with severe acute malnutrition and the chronic infections. Climate has a very minimal role, that during spring there is increased growth and summer there is decreased growth. But it is a very negligible influence, and usually catching up of growth is there. Emotional factors, again, I have told you, cultural factors, that the methods of prenatal feeding or pre-lacteal feedings have very negative influence in later on than the bottle feeding and all that cultural factors. Or putting, they put oil inside the ear, so which might cause recurrent meningitis or recurrent CSOM, ASOM to the patient. So again, recurrent infection will hamper the growth of the child. And parental education is very important, that early, when their child is sick, they are aware earlier, and they rush to the doctor, or they avail treatment earlier, and they tend to stick more to the completion of the therapy, and they usually do not default in the therapy. Now, there are a few definitions that I want you to remember. So, what are the periods of growth? So, in periods of growth, when do you call it as ovum? It is 0 to 6 weeks. Embryo, 3 to 8 weeks. See, this questions are the terminologies that we use are very much asked in exams, and they are regularly asked in exams. So I request you to memorize them, because they are They are asked again and again, and they are very simple questions where you can easily, answer them. So when is fetus called fetus? 9 weeks to birth, and perinatal period is 22 weeks to 7 days after birth. Okay, these are the prenatal period. Now postnatal. So newborn, infant, toddler, preschool, school age, and adolescent. Again, adolescent is divided into early, middle, and late. See, this terminology is given in Ghai, so it is asked again and again. Now, newborn is 28 days from birth. So, up to 28 days, it is called a newborn. And for infant, it is birth to 1 year of age. Toddler is 1 year to 36 months or 3 years. 3 years. Okay, a preschool child is 3 years to 72 months. Okay. And school age child is 73 months to 12 years of age. So this are the definitions. Early adolescent is 10 to 13 years of age. Middle adolescence is 14 to 16 years of age, and late adolescence is 70 to 20 years of age. So these definitions are very, very, very important, and you have to remember this for all examination purposes, because it is asked again and again and again. Now, look at this image. This image is very important. These are the rate of growth. This is the chart of rate of growth of different tissues and organs in pediatric population. So look at the growth of brain. See, this is brain growth. So as you can see, brain growth. So at birth, 65% of brain growth has already occurred, and at age of 2 years, 90% of growth has already occurred. Look here. At 2 years of age, 90% of growth has already occurred. So the initial years are very important in the brain development of the child. Later on, the maturation of the nervous system will occur as the age progresses. Because then you will ask me that, okay, at 2 years, if the 90% growth of the brain has already happened, then why is the 2-year child not 90% as intelligent as I am? So maturation occurs throughout the life, and it progresses throughout the life. But the growth, not the development, the growth of the brain reaches 90% at the 2 years of age. Okay, and the development sometimes takes time. Somatic growth, again here, initially somatic growth occurs, and then again it increases at the puberty of the child. So this is the somatic growth chart, and this is very important because it goes like this. It is a S-shaped curve, and it goes like this, and it is associated with 2 spikes of growth. 2 growth spurts are there, one at early childhood and second at puberty. Now, lymphoid growth is very important because lymphoid growth peaks at mid-childhood. And why tonsils become a hassle at mid-childhood? You can see over here that the tonsillar growth is maximum during mid-childhood. And that is why we get this adenoid issues and the tonsillar issues in the mid-childhood, because lymphoid growth is maximum then. Now, gonadal growth, again, it happens only and only after puberty, and before in pre-pubertal child, it is nearly juvenile, and there is minimum to no growth in pre-pubertal years of gonads. So these 4 charts I want you to remember, and these are given in Ghai, and that is why you have to remember, because they might draw any of one of this chart, and then ask you that, okay, tell us that what this chart shows growth of which of the organ or which of the system. Now we will go into somatic or skeletal growth. Now, when we use the word skeletal growth, this MCQ, you have to remember that skeletal maturation closely, see, maturation, skeletal maturation closely follows or correlates with sexual maturity. So this is a MCQ that might be asked, that skeletal maturation is associated with maturation of which of the system. So it is sexual maturation, because as you know, as the child grows in age, like 18 years, see, final growth plate closure occurs at 18 years in females and at 20 to 22 years in males. And once this growth plate closes, the diaphysis fuses with the metaphysis, and then there is no epiphysis. So after that, increase in height or in bone growth is not possible, and there is fusion of the growth. That is why we usually, use bone age as estimation of the age of, in the forensic medicine. So you have to remember this, that skeletal growth or skeletal maturation directly follows sexual maturation. Next, we will go into assessment of physical growth. So how do we assess physical growth? So here are the few pictures that I want to remember. This is weight measurement by beam scale. Okay, by beam scale. And this is very accurate, and this spring beam scale, it is spring based mechanism, and they might be electronic and they can be analog, and again nowadays electronic has been recommended because again they are more accurate. So this is used for tarring and measurement of weight of a infant who cannot stand. This is the photo of an infantometer. And infantometer, as you know, it is used for less than 2 years of age, to measure length. Okay, it is not used to measure height, it is used to measure length. Okay, now this is a height based stadiometer or a wall based height measurement, and this is used for more than 2 years to measure height. Here you have to keep in mind that, see, the child is not wearing any shoes, and there are 5 contact points, 1, 2, 3, 4, and 5. There are 5 contact points present, and these 5 contact points should be maintained in order to get the most accurate height. And again, this is called as Frankfurt plane. Frankfurt plane is preferred, and in Frankfurt plane, naked, they should not have shoes, so naked foot should be there, and all the hairpins or any special hairstyle if they have done, you have to avoid that, because it will cause falsely increased height. This is measure of MUAC, and it is measure halfway point between acromion and olecranon. Acromion process and olecranon process. So halfway of acromion and olecranon process, we see the mid upper arm circumference, and it is, as you know, age independent marker of growth, and it is usually stable between 6 months to 5 years of age. So it is the important criteria for severe acute malnutrition in the patient. We can also use MUAC tape, the tape that usually you see, the green and red color. It is not Shakir's tape, it is MUAC tape, and that tape may be asked as an image based question, that where is it used. So MUAC tape is used to measure MUAC. So I hope you remember that. Okay, now what are the anthropometric values? So what some important MCQs I want you to remember is, so age, weight, height, and head circumference. Okay, 6 months, 1 year, 2 year, 3 year, and then there is 4 year. We'll go that. So at birth, oh sorry, we forgot birth. So at birth it is 3 kg. At 6 months it is 6 kg. It doubles. Okay, so where does your weight double? It doubles at 6 months of age. It triples at 1 year of age, and it quadruples at 2 years of age. So this is what I want to remember. Doubles, triples, and quadruples at what age? Okay, and again at 3 years it becomes 5 times. 5 times. Now for height, there is a simple formula that, at birth it is 50 centimeter. At 6 months you have to add 5, it is 65 centimeter. At 1 year again you have to add 10, so it is 75 centimeter. At 2 years you have to add 15, so it is 90 centimeter. So here plus 5 plus 10 plus 15. So this is how you remember. After that, the formula gets a bit hazy. So up to 2 years, you can easily do plus 5, plus 10, and plus 15, and you will get the expected height in the patient. Head circumference, you have to see at birth it is 34 centimeter. Then it is 43 centimeter. You have to add 7, and then you have to add 4, and then you have to add 2. So estimate, if you take here as 8, this is what you get. So 34, 43, 46, and 48. So this is how you measure head circumference. So these are some cheat codes: plus 5, plus 10, plus 15, and plus 8, plus 4, plus 2. That you have to remember for estimated height or estimated head circumference at a specific age. Okay. Now, as you know, the weight gain is very, very important. Initially, there is loss of weight by 10%, and this is how you plot the weight chart. And there are the charts or Z-score or WHO Road to Health charts by David Morley, and we will see that in image-based session that how will you see or how will you plot the growth charts. And in growth charts, we see Z-score. What is Z-score? Observed value minus mean value upon standard deviation. So that is the Z-score, and this is the formula of Z-score that you have to remember. And the growth charts usually we see are WHO growth chart, and they are also known as Road to Health. And even IAP has come out with their own charts, and we can use them to measure growth. That you have to remember. Now, in the next lecture, we will see the disorders of growth that we see. And I guess that's all for today's lecture. And I'll see you in the next video.